title of my talk is The Terror of Cancer, The View from the Other Side of the Hospital Gown. My name is Patty Jekyll. I'm an oncology nurse specialist from Santa Monica, UCLA, and also an associate professor at UCLA School of Nursing. I have been an oncology nurse for 36 years. I was diagnosed with stage 3 lobular cancer, and that's why I decided to do this talk. So one of the things that I learned along my journey with cancer was that having to wait for your diagnosis and your biopsy results can be very stressful. And I didn't understand that I was actually doing what I was doing until I started looking at the theories. So the praxis theory of suffering, and suffering is a response to a threat to one's psychosocial health by potential loss. There are two major states. The first state that a woman waiting for her breast cancer biopsy would be enduring for preserving self. And I found myself in this state. You're robot-like, you move around, you keep moving forward. Even though I went to work after I had my biopsy, I thought, what else would I do? Do I have to go home? What can I do? But women preserve themselves by moving forward. They care for themselves and others. They keep moving. The caregivers at this point, you as oncology nurses, you need to maintain a respectful distance. The last thing that a woman needs when they put up their wall to be able to wait for their diagnosis is to have empathy and sympathy. That's really hard. So really, as healthcare providers, you should refrain from touching them and try not to be too empathic and sympathetic, because that kind of makes their wall come down and kind of makes them fall apart. And we need to do this because it helps us deal with the next stage, which is the emotional suffering. And I know when I got my final pathology back, I suffered. It was really difficult. And we need to build our strength. That's why we preserve until we have the news. And at this point, you can comfort patients. They'll send the comfort me signals. It's appropriate to hold, listen, and comfort them. And individuals move back and forth, between treatment. When they start new treatments, they may go back into preserving themselves, or they may move forward into more emotional suffering. What do we do to endure? Well, we rely on our families. Many people rely on their religious beliefs. I was big on the exercising. I kept going to the gym, even though I just had a breast biopsy. I said, I got to go to the gym or I'm going to go crazy. Like I said, acting normal, taking care, going to work. And then many people seek information. That was not something I did. I found it really difficult to go look up my diagnosis online. I can't even to this day tell you what the survival statistics are for patients with stage 3 invasive lobular carcinoma, but other people find it helpful to seek out the information. So I was put on a clinical trial because chemotherapy wouldn't work for me because my Ki-67 was less than 10%. I was fortunate enough to get put on the NeoMonarch phase 2 trial, which was a CDK4/6 inhibitor combined with anastrozole. I was able to do that for 6 months before I had surgery. And Dr. Sarah Hurvitz reported out at San Antonio Breast Symposium this year that the CDK4/6 inhibitor reduced the levels of Ki-67 in hormone-positive, HER2-negative breast cancer patients. And there's a correlation between reduction of the Ki-67 to improved outcomes. And at this point, it's a concept study, so there's no change in the standard, but we know that it does decrease the Ki-67. So telling others, I went to this great website after I told everyone I had to tell, but breastcancer.org has so many great suggestions, and it was right on for me because it's really hard. It's exhausting to have to go and tell people. My husband and I actually did create a plan how to tell our young adult children, and that was very helpful. And I used text messaging and email because I was worn out having to tell people. And that's okay. I don't think some of my friends were happy to learn that way, but it really helped me. And help your patients understand that family and friends may not respond the way you want them to. Some people they're not unkind, they just don't know what to say. And they may look for reasons. One of the things I got is, well, why did you get breast cancer? How come you got breast cancer? You haven't had red meat in 35 years. You exercise all the time. I couldn't answer that. I don't know, and that's not helpful because I'm already in that state of saying, why me, why me, why me? And the cliches of be strong, stay positive. If anyone can handle it, it's you. That's not helpful because you don't feel like you can handle anything at that point. And remember, you have control over the information. And I got really upset when people would go and tell other people without my permission. I always say it's my story to tell, so make sure I'm the one telling it. So some of the unsupported comments that I got along the way was one from a technician in MRI. She said, "We're rushing your biopsy because your MRI looks so bad." I didn't need to hear it that day when I was going in for the biopsy. I heard 100 times over. My tumor was large, so 100 times over I heard, because it's so large. And every time I heard that, it was a knife in my heart. You're so strong, you're my hero. And the same technician, when I went back in for the second biopsy while I was on the clinical trial, she said to me, I said, oh, my MRI looks really good. She goes, yeah, that's great, because I really thought you were someone that would not do well. She was not a mean person. She just didn't have the ability to say the right thing. And at that point, I was the patient, not the nurse. So I didn't correct her. And someday I'll have to go back and circle back to her. You're so lucky you don't need chemotherapy again. That was hard to hear. And then if I didn't tell people and I ran into them in the clinic, it was an issue. I had to have a mastectomy again because of the size of the tumor. And I went to my medical oncologist and I said to her, why am I not doing bilateral? Well, she peeled the paint off the wall with her very strong response to me. She said, we are not mutilating women for unnecessary outcomes. So I did not know that they were going to be published in the Wall Street Journal the following month talking about that. But there's an article that was in JAMA, and it was a retrospective chart review on 1.2 million women. In 1998, 1.9% of those patients that had stage 1 and stage 2 had doubles. 2011, it was up to 11.2%. That's a pretty big jump. And the study released in 2014 said that double mastectomy did not improve survival versus lumpectomy and radiation. So again, her thought was, we're mutilating women for no apparent reason. And part of that is the pink ribbon culture. There's more women that are younger, more sophisticated. There's a network out there, so they talk to each other. And of course, the Hollywood effect is that, implants aren't a bad thing anymore. And this is the article that was in. If you want to look it up, it's actually quite good. And then the next stop, after I had my surgery and I recovered really well, in 5 weeks I was back at work, was undergoing radiation. Radiation is not easy, it is difficult. You can be lonely, you can have anxiety while you're laying there. The side effects that I experienced afterwards was the profound fatigue. You can see this woman has terrible skin reaction, I also had that. And I actually had nausea. Everyone kept saying, you won't have nausea. I had nausea. The NCCN defines fatigue as persistent subjective sense of tiredness relating to cancer. 75 to 77% of breast cancer patients undergoing radiation experience fatigue. It is really bad. They're looking at the pathophys behind that as an activation of pro-inflammatory cytokines, possibly. Treatment is to get up and move, and that was hard for me to remember, and I'm actually in this photo, I'm with my body pump class where I go every Sunday morning. And the PEP cards for ONS has established that exercise is effective, and it's hard to have a fatigued patient get up and move. The other upside of exercise after a mastectomy is it decreases the chance of lymphedema, and I've been really fortunate. This is progressive weightlifting. I've been really fortunate not to have any lymphedema at all. The other problem that can happen with radiation, chemo, and I happen to be on an AI, is cognitive impairment. I used to be kind of smart, and I've lost some of that along the way. 70% of patients on the Livestrong survey said they suffered from chemo brain. You can rehabilitate yourself with this brainhq.com, and it actually gives you exercises to help with memory. On the aromatase inhibitor that I have, cognitive impairment is very apparent. There's non-adherence in 60% of the patients because of the side effects of that, and we know if you stop taking your AI in less than 10 years, you're going to have problems. I have to say that the inhibitor, the joint and bone pain, I was not prepared for, and I feel 20 years older than I am getting up and down. There's a recent study that was through ASCO that Cymbalta actually helps with the joint pain. I have not tried it yet, but I can tell you, when you talk to your patients, let them know that the joint and bone pain can be a problem. And the last elephant in the room is the fear of recurrence. It's not something we have a lot of good research on. Patients find themselves insecure, isolated, afraid, they feel abandoned, and I can't tell you how many times patients have finished chemo for lymphoma, for sarcoma, and I'd say, now go do good things, you're past this, go live your life. And they don't really want to hear that. They feel like we abandon them. 40 to 70% of the fear can be chronic and disabling. It can affect many parts, and they don't feel like they can discuss it. And I understand that. I have not discussed that with anyone. So getting back to work after I've been through all of this, survivorship care is really important to help us manage the side effects of treatment. For me, the longer term concerns are for cardiac and bone health. Obviously, the AIs decrease your bone health, and cardiac because I was irradiated on the left side. And health promotion should emphasize the benefits of an active lifestyle, and we should support that. And being back in the saddle means you have anxiety. Newly diagnosed 50% of people said 50% of them had severe anxiety, chronic anxiety in 30% of patients after they've had the diagnosis of cancer. And Nancy Jo Bush presented on this a couple of years ago at ONS, and PTSD is a problem for people with cancer. It's complex, it's a chronic disorder, it's usually triggered by a traumatic event. Childhood traumas are identified as a risk factor, so we as healthcare providers need to make sure, because having cancer and cancer treatment can definitely trigger PTSD. So I like this quote. It says, "To conquer fear is the beginning of wisdom. I'm conquering my fear."